First off, I'd like to say, mirror what Kian said, and it's very humbling in hearing the stories this morning, and you know, it lights a fire in my belly for what we're doing. So thank you for the opportunity to be here and talk to you. I will be much less clinical than Kian's chat, that's for sure. So to give you a bit of a background about me, I was a cancer nurse for 20 years, 17 of which I spent in radiation oncology, which I fell into. There'll be a lot of Kelly falling into things. A big believer in the universe finds you, and yeah, was working in leukemia, doing bone marrow transplant, doing shift work, working night duties, and someone said, oh, there's a position in outpatients, 9 till 5, which is nursing gold. And found myself in radiation oncology, and very quickly fell in love with what was happening there. So 20 years of that, and then fell into research. I had was still working a bit on the wards and a bit in outpatients, and one of my old nurse unit managers came up to me and said, oh, Kelly, do you want a secondment off the ward doing data collection for 3 months? What good beauty, everyone wants to get off the ward for a bit of a break. No night duty, no late shifts, no shift work, and found myself in the bowels of the hospital flicking through patient medical records and collecting data for Canteen. And then from there found myself in a position with Youth Cancer Service as a research nurse. I then very stupidly went on and did a master's in cancer research and sciences, and found myself 10 years ago in the thick of research land. And now also very stupidly, because I have Dr. Lee pushing me on doing a PhD, which is looking in cancer survivorship. So specifically in these late effects and what's happening it's not just one thing that we're curing cancer, but we need to give patients a quality of life, especially later in life. And that's certainly something that I've seen as a cancer nurse. So that's where my passion lies. So you'll see that coming through in what I'm talking about today. I'll start with just an acknowledgement of country. The research that I do is done in South Australia, which is Ghana country. So I would like to acknowledge any First Nations people in the room, and any past elders emerging and present. So I thought I'd start with what is a clinical quality registry. Besides it having a very big name, it has a very big purpose. So a registry of this sort, it collects. A lot of us get very funny when people call it a database. It's not a database. It's not a fancy spreadsheet. It's a very complex system that collects data. We use that to analyse health-related information. So it can be used for clinical trials, as a backbone to clinical trials. We're seeing a lot of that emerging at the moment. You can use it for safety and quality initiatives. For hospitals and healthcare centres, they have to have a healthcare component to that. There is health and quality standards, and collecting this data is a huge component of that. So it also can support the system that is a centre. It also is designed to improve. It's all about an improvement initiative. It looks at benchmarking specifically, especially within the cancer space. Many of you would know that there's optimal care pathways, which talks about when a patient should be diagnosed, for how long it is till they are treated, all of those sorts of things. So we collect a lot of those benchmarking moments as well. And again, it can be used as a backbone for clinical trials, but it can also be used for data management within a sector. It also helps improve and track long term. So a registry is all about long term. It's not short, it's very, very long. And that's certainly what you'll see within the registry as we go through it today. It also helps identify where these lapses are, especially across services. So to give you an example, there's a big registry that's running nationally in Australia that looks at ED waiting times, and they're able to compare the emergency departments across different jurisdictions within Australia, and how come they're doing it better than them, and what is the rationale behind that, which I think is a very important thing, especially when you consider that in Australia we have only one radiation oncology registry, and that's a spine. And obviously it's managed under very strict privacy and ethical guidelines. So the data that we collect is very much governed, and anyone that works with me will know that I'm an absolute stickler for the rules, and there's no fudging, there's no nothing, and you know, and the people that I work with, we all take that very, very seriously. We've got patient data, and it's a, you know, it's a medical record that we're going through. So I find that very personal for me, that this is someone's parent, this is someone's daughter, this is, you know, and that data, it has to be governed, and it has to be governed appropriately. So how did the registry come about? So back in 2020 and 2021, SAMRI, the South Australian Health and Medical Research Institute, I'll spell out all of the acronyms, and we'll come to this later as to why I spell them all out. And it's because there's a certain man in the room that it will get stuck into me every time I say an acronym and don't spell it out. So we're going to see how many I can do today and how many I can spell out. So SAMRI, the South Australian Health and Medical Research Institute, lobbied the federal government here in Australia for proton therapy to be listed on the MBS, the Medical Benefits Schedule. There's a lot of acronyms. And so what happened is part of that is that you provide evidence to the Australian government, and you say, hey, you know, there's advantages to treating this, and we should bulk bill for that, and it gets listed, and you get MBS codes, and then that way you can bill for it as a health service. So they lobbied in 2018, which was unsuccessful, but then they had another crack at it in 2020 and 2021, which was successful. And the following tumour streams that are all listed up there were listed on the MBS, meaning that any proton centre that started in Australia could bulk bill and use these MBS codes to treat these cancers. At the same time, the Australian government, which is probably one of the really good things that they've done in this whole proton situation, is that they identified that a lot of the data that exists internationally, because obviously we have no current Australian national data, was a little bit loose. A lot of the centres that are international started using proton therapy, treated with proton therapy, and then started saying, oh, look, let's get some research comparing protons and photons, like let's compare the two. But of course, they've now got protons, so they're only collecting proton data. Who's collecting the photon data? So of course, this is where we come in, because we're not treating protons, we don't have a proton machine. We can start collecting the patients that would otherwise be eligible. If we had a proton machine sitting somewhere here in Australia, these patients would go to that facility, they'd be treated with this diagnosis, and and they would be MBS billed. So of course, they said, okay, let's start a registry. Let's start collecting the patients that would otherwise be appropriate for proton therapy. So this is the largest data set in the world of proton versus photon therapy. At the moment, it's only photon, and the protons will come. So internationally, all of those other centres are treating with protons, so they're getting a very small cohort of photon patients. The photon-proton thing just kills me, right? We're not just decide to just call it something completely different, but no, we make them so similar that it's confusing. Then back in 2023, have I written on it? Oh, look at that, August 23, the brain was working. The Cancer Australia brought out a strategy for proton therapy in Australia. As part of that strategy, they identified a number of different things. One, that we needed a registry to collect the data. But one of the key things that they recognised was that there was emerging evidence internationally for other tumour cohorts. So that includes breast, head and neck, and esophageal. So in November of 2023, we included that on our protocol, and we started collecting those patients. So as you can imagine, going from a very rare cohort of patients, and we were collecting maybe 1 or 2 patients at that stage in South Australia per week, it then exploded because we've now got left breast and esophageal and head and neck. So we haven't expanded those indications nationally, mostly from a resources perspective. There's not enough data managers nationally for us to be able to do that, but we are doing that at the Royal Adelaide Hospital. So what is Aspire? What's it about? How does it work? So it's one of 5 registries of its kind in the world. So it's the only radiation oncology registry in Australia. And of course, we're collecting those photon eligible patients. So we're looking at those mostly paediatric and AYA, as you've seen from that MDS list, but like patients like yourself, we're looking at those really rare cancers, those ones that often don't get the limelight. And obviously what we're looking at is we're describing the patterns of care. So what are the side effects that these patients are experiencing? So what you're seeing up there is the two different populations. They were actually stipulated by the MBS, so MSAC, the Medical Services Advisory Committee, my friend down here. Although he knows them all now anyway. But yeah, so these are the things that we're specifically looking at. One of the big things about the registry, which I kind of feel like is our gold star and our little claim to fame, is that a lot of the other registries around the world will collect this data, but a lot of them don't grade the toxicities. So a lot of you would be aware perhaps of the CTCAE, there's another one, which is looking at the adverse effects. So what are the side effects that patients are experiencing, and we grade them. So a patient that's having pain can be graded at 0, which is no pain, and then we can have a grade 1, which is it's affecting them slightly. Grade 2 is that they're requiring interactions, so whether that's a medication or some form of physio or something like that. And then obviously you go up to grade 4, and then there's grade 5, which is death. So a lot of the registries will collect this data, but they don't grade the toxicities. So what they're doing is saying, does this patient have pain? Yes. Does this patient have fatigue? No. But of course, what we want to know is how it's affecting their quality of life. So you could have, as I'm sure many of you in this room can totally appreciate, you can have a patient that has pain, and it means that today there might be a flare-up and it's a little bit sore and they have to rest a little bit more, or perhaps they, in a situation like this, they need to stand up at the back of the room for a little while. But then you can have a patient that's chucking down endones like they're Smarties and is unable to function. And their grading is going to be very different to the others, but both of these patients on any other registry are a yes. So one of the important things that Hien and I, when we were creating this with our team, was that we wanted to grade these toxicities. We really want to know what the impact is happening on a patient's quality of life. Because there's, as far as I'm concerned, there's no point collecting it if you're just going to say yes or no. And there's nothing to compare it to. So how did we create that? So MSAC said, yep, you need to have a registry, and of course you need the almighty dollar to get that going. So big shout out to the Hospital Research Foundation, who to date have funded the registry 100%. So those of you that aren't from South Australia may not be aware of it, but it's a research philanthropic group that take donations from a range of things. They do those home lotteries and all of that sort of stuff. And Paul Flynn, who is a cancer survivor himself, is a huge advocate for seed funding and starting things off. And Aspire is obviously required as an operational component. You need to have the registry in order to get the MBS funds. So he funded that until we have a centre available in Australia, and Aspire falls under their operational funding. So we received funding from them in July of 2021, which is when I came on board, and since then we've had a few more reiterations with that grant. So that set up all of our ICT and all of those sorts of things, and obviously our staffing. So there's some of our team there in the earlier days, looking at us all young and fresh and not killed by the project yet. Look at Pete, look how young he is, looks like a young boy, right? So how did we design the registry? So fortunately, we were in a very fortunate position. Hien and myself had previously been involved in the PTCR registry, the Pediatric Proton Photon Consortium registry from Massachusetts General Hospital and Harvard University. So they were one of the very first ones to recognise with their registry that they needed some photon data. And Hien had spent some time over there with Torren, who was their chief principal investigator, their CPI, and she reached out to Hien and said, hey look, it would be really great to start collecting some photon data, because we're not collecting it here because we're treating with protons. So started a nearly 4-year journey in bringing a registry that's collecting international data, and the Royal Adelaide Hospital is actually the only site outside of America that is collecting photon data on that. So Hien is the principal investigator, the PI here for Australia, and I project manage that. So we had been working on that project for a little while. We knew the data sets that they were collecting. We also reached out to colleagues that were part of these other registries and worked out what are the common denominators, what is everybody collecting, what's important information. There's also the Meteor, which is the metadata something for the Australian Institute of Health and Welfare. And Cancer Australia and a whole range of different people are involved in collecting and saying what are the minimum data sets. So if you're going to collect a patient's demographics, then we want their postcode for their relative remoteness. We want to know whether or not they're Indigenous, their ethnicity, are they culturally and linguistically diverse. So there's a minimum data set that if you're going to start collecting this data that you should do, and it's set up then for international linkage, which obviously being one of only 5 in the world, you want to make sure that you guys are talking the same language, okay? Even if you're from a different country and you're not speaking English, is not your first language, the registries can all speak to each other because we're all collecting that minimum data set. So that was what we did up there with Meteor. Then obviously we invited our friends at TROG, the Trans-Tasman Radiation Oncology Group. So they run and oversee, they're a major stakeholder within the clinical trial space within Australia, and especially radiation oncology. And we are badged as a TROG registry. So we reached out to them. They have a scientific committee, and the scientific committee reviewed our protocol, what our plans were, all of that kind of stuff. Stakeholder engagement, especially when you're talking nationally, is really, really important. As Hien has mentioned before, and there's been questions about those people talking to one another, it's really important that you have that engagement. Then obviously we drafted the protocol, then we looked at the other registries, and look at all those acronyms, Nick, you'll be loving that. So the NHS is obviously the health system over in England, the European, and they've all got registries of a same nature. So we looked at what their data sets were and compared them to what ours were. Were we missing key components? And what should we be collecting? Then you have to talk about the data custodians. So the data custodians, I'll point out, are the patients because it's their data. So first and foremost, it's owned by the patient. But secondly to that, the server that controls our RedCap for where all of the registry data is inputted is based at SAMRI, so South Australian Health and Medical Research Institute. Again, this was a really important thing because when you're looking at national data, it shouldn't be owned by a single health service, okay? So even though we're very closely affiliated with the Royal Adelaide Hospital, and then obviously there's the Australian Bragg Centre, which is who I work for, my work is actually done and held by a medical research institute. So SAMRI is one of 2 registry centres in Australia, the other is at Monash. So it obviously made sense, being that we're based in South Australia, for it to land in South Australia. But that data custodian sits within a health and medical research. It's not owned by the Bragg Centre or any other Proton centre that would be around in Australia. It's owned by a health and medical research institute. So this is a very busy slide, but this, I just want to show the work that's involved in setting up a national registry and ensuring that you've got national buy-in and you've got national stakeholders, because then that gets everybody at the party. Everyone gets an invitation, so everybody wants to come to the party. So obviously at the top there's SAMRI ABC, so what was involved in that. So there's the funding, the ICT, the registry centre, all of the working groups. Then we've got our engagement and stakeholders, and there's a lot of stakeholders that sit within the nation. And then obviously registry design and endorsement and registration is really important. Anybody can just go and set up a registry and say, yep, cool, this is what we're doing. But if you open up your protocol to all of the different organisations for them to really have a good hard look at what you're collecting, they will endorse you. And then that shows that there's a little bit of credibility in the data that you're collecting. And then obviously the protocol, again, lots of acronyms, but Department of Health and Aged Care, the Australian Institute of Health and Welfare, There's a lot of things that need to be considered if you want to collect data later, Medicare numbers, patient privacy, all of these sorts of things really need to be considered. So it's not something that you can just go in and do on a whim. So ethics and endorsement. So that's the next thing. Once you've got your protocol and you've got all your stakeholders and everyone's at the party, then you have to get the biggest person of the party, and that's obviously your ethics. So you want to go through an ethics committee. We made the decision being that it was going to be a national registry, that we went through the National Mutual Agreement, the NMA, which is a more rigorous process. But it ensures that those states that recognise the NMA, that you can get approval through their governance. So we've also gone through the Indigenous data sovereignty, and we've also gone through the Northern Territory, because they have their own privacy act that's very specific to NT patients. And then obviously Sydney also have the same. So there's certain jurisdictions that don't accept the NMA, but they have their own privacy policies. So we've gone through that. And then obviously the collection of Indigenous data, which is something that is very, very important, and we need to make sure that we have First Nations people involved in that. We've also been endorsed and badged by TROG, and then we've been approved and registered with the Australian Clinical Trials, and also recognised by WHO, the World Health Organisation, and have been given a clinical trial number. Again, very important. And also one of the biggest ones is endorsed and recognised by the Australian Commission on Quality and Health Aid. So that goes back to those health policies and what sets us apart from being a clinical quality registry to just a registry, which we'll get into a little bit more and make a bit more sense. So what do we collect? A whole bunch of stuff. So the registration form, that's our minimum data set. So every patient that is eligible for the registry and enrolled onto the registry, we collect the registration form data. That's been ethically approved. That's how we know that the average 45-year-old male does not consent to being involved in clinical trials in Australia. So this tells us, it also means that we're able to pick up if there's any discrepancies. So let's say we've got a lot of culturally and linguistically diverse patients opting out of the registry. They don't want to be a part of the registry. So we then look at that and go, okay, do we need to provide information sheets in certain languages? Is there a deficit? Are we missing out on those male 45-year-olds? Is there a certain health service that are getting a lot of the opt-out? The registry, when I say opt-out, so there's two different types of ways that you can do consent in Australia. One is opt-in, which is where I sit down, we have a really big chat, I give you a whole bunch of information, you go away with that information, you come back and you tell me whether or not you want to be a part of the clinical trial, we sign a whole bunch of paperwork, and you're on. The other option, especially with something like registry data, where we're talking about a huge cohort of patients and very resource intensive to sit with every patient, what we do is we have an opt-out consent model. So all of the patients are provided with a patient information sheet, which is actually in your folders today. Every one of those patients that is eligible within that health service is given a patient information sheet. They're spoken to about the registry, what we collect, the purposes behind it, and that sort of thing. The patient then has 14 days to opt out. So they have 14 days to sit and have a think about that. All of our details are within that patient information sheet. They can go online and have a look at our website. They can look at any of the data that we've put out, any of our infographics. And if they don't want to be a part of that, all they need to do is contact us by phone, by email. We have a website that you can contact us through, and even just your own health service. You can just say to the doctor then and then, look, I'm not interested in being part of it. And then what will happen is the registration form is completed, and then we're told that the patient opted out, and sometimes we're given a reason for that. Once that 14 days has lapsed, then we then enrol the patient onto the registry, and all of the other data sets become available for us to complete, which are done on site. Some are done by the clinicians, some are done by data managers, some are done by research nurses, some are done by radiation oncologists. So it's a very multidisciplinary approach to collecting the data. We then obviously look at patient demographics, patient diagnosis, family history, is there a family history of cancer? Multidisciplinary team. So this goes back to one of the Cancer Australia objectives, and that is that every patient should be discussed in an MDT prior to their treatment starting. So this is one of those benchmarking things that we're able to compare states and say, are all of those patients being discussed by a multidisciplinary team? Is everybody in the room when the discussions are being made about these patients? And is it before their treatment starts? And we're able to provide timestamps and whether or not that's a benchmark that all of those states are collecting. We also look at any allied health services and any work at, with our cancer care coordinators involved, especially if they're a country patient or they're coming from a remote. If they're an Indigenous patient, are they getting a cancer care coordinator that, it is an active cancer care coordinator. Fertility preservation, this is a big one close to my heart. I previously worked with Canteen on an onco-fertility registry, collecting data for adolescent and young adult patients, and we heard Sophia talk before about what's going on for her. So it's really important that that data is collected, because it's one thing again that we're curing cancers, but what's happening later for these young people? Are they going on to have a quality of life and living the same life as their peers? Fertility preservation is a huge component of that. And we know through the work that I was doing with Canteen that a lot of young adolescent patients are not being offered fertility preservation prior to their treatment, and that really needs to get better. So this is something that we can show. We can show in certain states. In South Australia, fertility preservation is free if you're a cancer patient, and the storage of that for up to 10 years is free. It's the only state in Australia that offers that. So if we're able to show that a free service is putting more patient fertility preservation on the go, then those things should be happening in all of the other states. Clinical trials. So again, this is another key performance indicator, KPIs for the acronym people in the room. So what happens is these are very important in making sure that all of the patients, so Canteen have come out and said in their Canteen vision is that all young people with a cancer diagnosis should be enrolled on a clinical trial. We know that patients on clinical trials have better outcomes, they have more services available to them. So it's important that we collect that. We obviously then look at medical imaging, so how was the patient diagnosed, CT scans, and then obviously the types of treatment that they've had and the intention of that treatment. Then we go into any current and prior radiotherapy, any surgery, obviously any chemotherapy, systemic therapies, immunotherapies, hormone therapies. And then we do an assessment, so a baseline assessment, so bloods, ECOG, so what is the patient's performance status and how are they going, and that's what we then use every year thereafter. And obviously any acute symptoms and toxicities, which again are graded. It's not just a yes and no. We actually want to know the impact that these toxicities are having on patients. And over the course of a period of time, we'll be able to see whether or not those toxicities are getting worse or better, and what interventions those patients are having at every yearly assessment. Then obviously we look at organ at risk specific testing, which is something that Kian and I have been working on. There's not a consensus statement in Australia for what treatment should be done. Patients, we've been talking about since 2003 that patients should be provided with a care plan and a survivorship care plan, but I've seen all too often that these patients would be coming back through cataracts in six-year-olds that were treated at 15 and 16, and they're not having yearly ophthalmology reviews, things that can just be bought with your local shopping centre. So we really need to have a coordinated approach for these organs at risk that have been treated with radiation. So that all seems like a huge amount of data, and you think, geez, you guys must just be sitting there all day doing stuff. But it actually takes, so the baseline data, what we're talking about here, takes anywhere between half an hour and an hour to add to the registry. I had one of the clinicians, and I don't know any other clinicians, there's a couple of clinicians in the room, so they might start throwing chairs at me, but he will protect me. I had a clinician up in Northern Territory, and he was like, oh, Kelly, I've never seen red cat before. I said, look, just log in, have a crack, you'll be fine. I'm here for you. And he rang me an hour later. He's like, it's done. I don't think it is. I don't think it is. And then I was like, are you sure, Ken? And he's like, no, it's all in there. I've put all the data in. He was so chuffed with himself. He's like, get on there. While I'm on the phone, get on there and have a look. I want to know. And I got on there and sure enough, he had inputted all of the data. So I say to all of my data managers now, if a clinician can input the data into the registry within an hour, then you've got it covered. So yeah, less than an hour to actually collect the baseline data. So who oversees the registry? So it's just not Hien and I's vision. We have a national steering committee, and we report to that national steering committee, and that national steering committee is part of the process. So when we got the protocol approved before we started doing recruitment, we put a EOI, an expressions of interest, out for all of the, went out to the TROG community. We also blasted it on the website, we did social media, and said, hey, look, we're looking for clinicians and people to be involved in a national steering committee. This ensures that the scientific integrity that sits there, we're having to report that to people, okay? We have a number of stakeholders on that committee, and we report to them. We also have the Chief Executive Officer, which is Susan Good, from TROG. She sits on that committee, and we have consumer advocates who you might recognise one of those young chaps on this picture. Look how much Pete's aged in this picture compared to the last. A few slides and we've added 40 years to him. He now looks like a man and doesn't boy with his beard. But this is our group of people, and these guys are all very heavily involved in the registry. We meet quarterly, we have our meetings, we catch up, we tell them what's going on, we talk about the data that sits within the registry. If anybody within any of the organisations wants to request data from the registry, which is allowed in a de-identified manner, every site has their own data that they can get onto at any time and run reports. They can just do that with me and Amber, who's sitting there next to me, who is our senior data manager. They can report to Amber and I, and we can help them at their own sites take their data. It's their data, they own it, them and their patients. But if they want to do a request for national data, then they complete a survey and that goes to the steering committee. So the steering committee will talk about whether or not that is appropriate, and of course, absolutely, most of the time it will be, but we need to make sure that these people are representing the patients appropriately when they're collecting the data and what their intention is, and the people on this slide make that decision. So I thought it was worth, while we talked about consumer and advocacy and research, I thought it was worth talking about, how we do that. When I first got into the research thing, this whole consumer advocacy thing was a big tick box for me, if I'm honest. It's like, have you got a consumer? Yeah, sure. And then you'd go to these meetings and they'd sit there and we'd be talking with all our acronyms, and and you've got all these clinicians and these big, smart, crazy people in the room, and and you'd be sitting there, and I felt so much for these consumers that was, and then it would be like, so what do you think, Jane? And Jane would be like, whoa, I was not expecting you to ask this, and there's no actual proper engagement. So when we made the decision to have a consumer advocate on that, and on my PhD with all of the survivorship stuff that we're doing, it was really important that we made sure that there was appropriate participation. So anyone that knows me knows that if I don't do tick box, we're not having a tick box, we actually want engagement. So we did an expressions of interest for our consumer advisory group that sits within the Bragg Centre. We have 15 people on our consumer advisory group. They're involved in all of that work. And then as part of that process we had, and it was very formal, you had your EOI, you had to give us your resume, we wanted to know your cancer journey, we really wanted to pick these people, and went through a full interview process. These are paid positions within the registry and within our Bragg Consumer Advisory Group. And we sat down as a team and found the most appropriate people for that. So there's two parts to it. Is one, there's the participation, but how do we facilitate that? How do we make sure that that person's not just sitting in that meeting as a tokenism of, yep, I'm the consumer over here, but I'm not actually giving any input. Nick and I and the whole Thompson family, that's what I say, I didn't just get Nick, I've got a whole family. We catch up often, so often outside of the meetings, and we have our own little banter that goes on. And it's about the acronyms, and he'll write down any fresh acronyms that have come up in the meeting, and we'll discuss them afterwards. If there's anything that I want to get his input on before the meeting, I'll let him know that. I'll say, hey Nick, you know, when I send the agenda out for the meeting, I'll then catch up with him. I'll send him a text or I'll give him a call and say, hey Nick, we're going to be talking about this and I'd really like to know what you think about that. So then that way there's some preparation time for him to be able to do that. So we debrief post, we often talk beforehand, and I've been very encouraging, I hope, of open dialogue, especially around some of the intricacies of the Proton Centre and what's going on there. Obviously what Nick is hearing outside and versus what's actually happening inside, because they're often two very different things. And making sure that I'm accessible to him. And that he can talk to me at any time and he feels like he can give me a call and say, hey Kel, you know, I didn't feel like this went well or that went well. And we often talk about what are the barriers to the participation, how can we do that? And then what is the participation? So it ensures a consumer-led focus to the research, what the data that we're collecting. What do you think about this? How's Sophia going with this survivorship stuff? You know, what should we do about this? Should we be collecting that? Should we do this? And there's been changes that have been very specific because we have people, I'm not a cancer survivor, none of us on that panel, apart from Nick and his family are. So what they give to us is very, very important from that aspect. And which takes me to the co-design, you know. This is a patient registry, so it can't just be designed by people that aren't. And the survivorship pilot program. Like I say, Nick has been involved in that for the last 2.5 years. We've worked together now for almost 3, which I only figured out when I was going through some of the stuff that's on the next slide. And you know, it really brings that lived experience for me as a researcher, and how we do that. And obviously, any of the patient information sheets, they've all been reviewed by the consumers. Our PROMs and PREMs, our patient-reported outcome measures and our patient-reported experience measures, we want to make sure that they're patient-focused. So not only do you get a consumer advocate, but you get a family. And they're like, oh my God, I can't believe you brought all these photos up. So this is some of our journey. So like I said, we get the family, like I've even got Harry down here. And Pete, so this was at Sophia's album launch recently, which we were so excited to get to. That's us up there at Adelaide Airport a long time ago, doing filming for the Proton Centre, and then we got bumped because something crazy happened. I don't know, a politician did something, swam in a pool with his shirt off, probably. We've had an aquatic centre open in Adelaide and everyone's gone mad about the Premier taking his shirt off. So Proton's got bumped for that, and we spent a day at Adelaide Airport filming, and we're all so excited we're going to be on the news tonight. We're all sitting there messaging each other and, no, sorry, bounced. So, you know, but we got a photo. And then Gather Round. We were involved in Gather Round, and Sophia went and opened it up and seen our man friend Patrick Cripps, and we did all sorts of crazy stuff together. So it's not just about that, it's about community, right?
Yeah.
So back to the registry. What have we done since March 2022? So that was when we started recruitment. We got approval in December of 21, and we started recruitment in March of 2022. So we're currently enrolled at 7 different sites nationally. Adelaide, Darwin, Perth, Melbourne. We have an Icon Cancer Centre in the private sector, which is very important because you know, we need to make sure that we're going across private and public. I also hope that we'll be able to show the private sector has a lot of wraparound services. So you'll remember before we were collecting them who was involved from a multidisciplinary team in allied health services. So in the private sector, they have a lot of wraparound. So if you think of head and neck patients, for instance, they have more dietetics and they do physio, they have all of these sorts of things that aren't necessarily available in the public sector. And what I hope to show is that through those extra wraparound services, it's actually saving money long term. And then that's what you can use as a business case to take back to that public sector and say, hey, look, you know, Icon in Adelaide are not getting the admissions and are not getting the side effects that these ones are, and that's because there's more allied health services involved. And that's what talks. It's all about evidence. It's all about creating evidence. And we also, just at the end of last year, got approval from Royal Brisbane and Women's Hospital. So I'll be heading up there shortly and doing their site activation, and they'll be coming on board, which is really exciting. So I broke down within the registry some of our chordoma patients. So I will start this off by saying it's a very broad overview because it's a very small cohort of patients, and I wanted to ensure their anonymity when I was presenting this data, which is obviously, as I said before, very, very important and important to me. So the average age of the patients that we currently have recruited on the registry, and I will remind you that obviously in the Royal Adelaide we've been collecting patients since 2022. So some of these other sites didn't come on until 23, 24. Some of them didn't even come on until last year. So there is some changes there. So the average age of the patients, the chordoma patients that we have in the registry are 51. And the ages range from 35 to 71, which is pretty similar to what Hien was presenting with the comparative planning. 75% of our patients on the registry are male and 25% female. We have 75% of those patients identify as being non-Indigenous. We have 25% that have identified as a First Nations person, and we don't have any culturally and linguistically diverse patients on there yet. As far as relative remoteness goes, over half of the patients are from a major city, so a place where radiotherapy is obviously actively available to them. But if you look, quite interestingly, regional and remote are very, very similar. So these patients are travelling for their radiation treatment. And their treatment modality, so 75% are surgery and radiation, and then 25% are just radiation. All of the patients very happily were discussed at an MDT prior to their radiotherapy commencing, but sadly, none of the patients were enrolled in a clinical trial, which is what we're seeing. So there a couple of the publications. So the Aspire patient information sheet, like I say, Kimberly got sent a copy of that, and that's all in your folders. This is the protocol that has been published. It's very user-friendly. It's not one of these, crazy scientific clinical trials type jargons. It's very simple, very plain language that talks about the protocol, what the data we're collecting, why we're collecting it. And then if you're really bored, there's the MSAC 1638 document, which is the application to get protons put on there. It's probably some really great toilet reading. It's pretty full on. So this is, as Hien has said, it takes a village. I'm but one member of that village, and this village also includes the Hospital Research Foundation, who without them we wouldn't have a registry. Child Cancer Research, and of course our Aspire Steering Committee, who do a wonderful job, collecting the data with us and telling us what we should do with it. Thank you.